the Operations Manager at the Advocacy Service at Favour UK. I've been working in addiction for 28 years. 14 of those years managing community addiction, community rehabilitation services. And then 4 years ago, I'd kind of had enough of banging my head off brick walls and seeing things, decisions around the standards, a shift towards NHS in terms of decision making. And I felt I just needed to do something else. So
Dougie, you need to speak up, there's people straining in the back.
I left to study law, so I thought I'd left the addiction field. But 3 years ago, I joined a group that was involved in Anne-Marie and Natalie Logan, who had decided to do something about the drug-related death figures that were released in 2019. And that's when Scotland attained the world record of having the worst drug-related deaths in the world. And it just felt that people had to do something because there was no response from government at that time. It was as if they were in a state of shock. And people from the ground level stood up and decided they had to do something. Within a week we had arranged a vigil at George Square, and then that led on to a sort of series of consultations across the north of Glasgow that would consult with people, family members, about what they saw as the problems, why people were dying. And Anne-Marie and Natalie together gathered up 23 recommendations and passed them on to government, but nothing really happened. There was a task force in place, and they seemed to convince everyone that they knew what they were doing. But 2 years later, the record levels kept continuing, and last year that's when the Advocacy Service was set up. And the purpose of that Advocacy Service was to assist the most at risk who were experiencing barriers in trying to access the treatment they needed. But we all wanted to do more than that. We wanted to try and help find the solutions. So it was also about gathering evidence of the barriers in the system that weren't just affecting those people but others, and then trying to communicate those findings to government and local authorities so that they could try and resolve the situation quicker to save lives. Because I think in relation to what Darren was saying this morning, and this social distance, policymakers were talking about, the Drug Death Task Force were talking about, this is what we're going to do at our next meeting, and then there'd be an announcement. At this meeting we sat and we watched this video about such and such, and you know, this created fury in people because they had limited time and they were wasting it watching a video together rather than making decisions. Whereas the people on the ground were conscious that every single day 3 people were dying. And those 3 people could be anywhere in the country, they could be someone you know. And that was the complete difference of perspective at different ends of the spectrum. So we did a report 6 months ago, and my colleague Alan Crone presented that at our last conference. I'm just going to do a quick update of that, and we can talk about how people have moved on since then. So in that period, we were commissioned to work with 40 people over the year because of the intensity of the work. But within that first 6 months, we worked in 7 local authorities, supported 21 people who were looking for treatment for themselves. Additionally, we supported 9 family members or friends who were trying to help on their behalf. With 30 first engagements, so that's the problem they originally came to us with. 15 second engagements, so after the first was resolved, a second issue was identified that they felt that we could help with, and then 2 further engagements. So 47 engagements in total. Of the case studies that we presented at the last conference, client A had been subject to clinical error by staff, and I'm going over these because I'm going to talk about some of the issues that we believe are relevant to the drug-related death situation. He'd been subject to clinical error by staff that involved him having an overdose in hospital due to wrong information in the past. We helped him to re-engage with the service because he wanted CBT, and we helped him access other services. Client B had been waiting for 3 years for a referral to residential rehab, and he felt he was getting completely palmed off by the ADRS, Alcohol and Drug Recovery Service. This was having a huge impact on his mental well-being for him and his family. We assisted him in putting forward his case, and he was referred to residential rehab fairly quickly. Client C felt he had been abandoned by ADRS and was heavily medicated, isolated and vulnerable to financial exploitation. Supported only by the family and was desperate to go to rehab. We assisted her to make a case for residential rehab, but in this situation that was denied, and what was offered to her instead was the stabilisation unit, which rather than helping people to become drug-free as she wished, it stabilised their medications probably at a higher level, but the aim was to keep her safe. But it was taking her in a different direction in terms of recovery. Client D found her drug use escalate, partly as a result of coercion and exploitation from two men in her local area. She was not safe in her house. When her request for residential rehab was denied, we pointed out that she could not return to her home because she was unsafe. This was still denied. We managed to find her a free place at a residential rehab. We thought everyone would be delighted. They then went out of their way to try and sabotage that referral because they didn't want to set a precedent of referring to a different local authority because their policy was to keep things local. So that was eventually resolved after we took it to the local MSP, and an apology was issued, and they agreed to refer her to the residential rehab and provide the medication and prescriptions that she needed. Two additional cases that we didn't mention the last time. Client E had recently been in residential rehab but had experienced a brief relapse. She believed that a methadone detox of around a month would be enough to re-establish her recovery. We engaged in December 2021 after she'd been told that she would have to wait for several months just to get a 1 month detox. With her money running out, she faced the prospect of having to return to crime of various forms to raise the funds to pay for it. The irony here is this methadone was originally introduced to move people out of crime and dangerous practices for their health in order to prepare them for rehabilitative work. We assured her MAT standards would be in place on the 1st of April, just to sort of keep her hopes up. We got to the 1st of April and it wasn't happening. And it didn't happen until she'd been waiting 6 months, which was, many clients would have probably collapsed at some point along the way and needed much more intervention at the end, which would have been tragic. The fact that she managed to hold things together and only needed that 1 month that she originally requested made the situation more ridiculous. Client F had waited for about a year for a referral to residential rehab, and his family were as terrified as he was that he might not survive. As soon as he became involved, we found the local authority had decided to interpret his frustrated email as a formal complaint. There was nothing in the email to suggest he wanted a complaint, but they seemed to take advantage of this in order to set the terms of the complaint so that they could then manage it in their own way. We managed to escalate that down, not least because the complaints procedure would mean that his treatment would be suspended for 20 days. He was then progressed for his referral. Everything was in place, everything was signed off, everything was agreed, except some paperwork he had to sign. He then was unwell one day, thought he had COVID. He tried to phone them, he couldn't. The next day, when he phoned them, he was told that the whole thing would scrap because he wasn't showing the appropriate motivation. So again, we engaged, and eventually he got referred to residential rehab after 6 months of mistrust and uncertainty. So that is that. Sorry, I was trying to think about the slide. Right, so this is the clients that I've just identified. I'm just going forward a bit. So that's them there, and that's their eventual outcomes. And I've sort of colour-coded them because what I noticed was, although it's a very small sample, could hardly be smaller, but it's quite an obvious demonstration of what happens if you give someone what they ask for, compared to if you give something to them that they didn't ask for. The two that wanted rehab and got it had a successful time in rehab. Actually, they've done absolutely brilliantly. One's now working as a volunteer, and the other, who they tried to block a referral on the basis that she was unfit in their eyes, she's now volunteering at the rehab because they were so impressed with her. The two that got what they didn't want obviously failed, and then the one at the bottom where he asked for rehab but was basically messed around for 6 months, it's maybe no surprise that he didn't quite last. So we hear a lot about residential rehab doesn't work, but we don't hear about how much interventions that people don't ask for but are imposed upon them fail. And we know that people are on alternatives to residential rehab for years. And it's hard to compare the two when they're measured in completely different ways. I'm conscious of the time, and there's a lot of reading in some of these case studies. These will be printed, published in the report at the end of the month. So what I'm going to do now is, there's 6 case studies from the previous report and 4 more that we've got here, so that's 10 case studies. And I'm going to read out a list of all the problems identified in just those 10 cases. There's been discussion this morning, and quite a lot, about the dichotomy between harm reduction and abstinence. And harm reduction is talked as if it's a list of medical services. But that seems to be a sort of new interpretation of what harm reduction means. Harm reduction originally was a practice, a discipline. Any intervention, you analyse and consider what the likely consequences are. If it's going to be beneficial, then it's harm reduction. It's a positive. If it's going to be a negative impact, then it's harm augmentation, and you avoid them. In the middle of a drugs death crisis, we kind of assumed that everyone would be working on a kind of risk management approach like that, considering everything they do to try and reduce the drug deaths. But we have concerns about all of these things that I'm about to list. Services avoiding clients that they've previously let down, waiting for years for a referral to residential rehab, being left without an appointment for months, forcing clients to wait months for a local rehab while beds lie empty in an adjacent local authority, the failure to implement MAT standards, specifically forcing clients to engage in criminal and dangerous activity while waiting for methadone, decision makers that never meet the person seeking help, decisions without reasons provided, no written reasons, decisions without an appeals process, adopting complaints procedures to handle client disagreement, contacting clients on phones with no ID, providing clients with monthly appointments. Appointments lasting only 10 minutes with discussion of nothing beyond medication compliance. Failure of services to publicise the manager's contact details. Failure of workers to provide workers' email addresses or phone numbers. Providing contact details for a preferred independent advocacy service but not providing details of others. Failure of adult protection and support procedures. Coercion of clients. Dual diagnosis leading to joint application of responsibility. Providing misinformation and revealing personal bias about residents' rehabilitation. This was a nurse who, in the middle of planning a referral to rehabilitation, told the client, "I don't believe this works." And in fact, in 20 years, I've only seen a handful of people that it works for. If only she would come to somewhere like here. A failure to recognise the impact of trauma and PTSD, stigma within the hospital settings and even addiction services themselves, lack of appropriate ward space in hospitals for people presenting in crisis, normalisation of social distancing measures from lockdown, wasted money, time and opportunities on referrals that clients did not wish. So that's the context of our work in trying to support people through the drug death crisis and trying to help understand what has made these sudden increases. When this year's figures were released, this was the statement from the Scottish Drugs Forum. The tragedy is that each of these preventable deaths represent an ongoing systemic failure to address poverty and support vulnerable people and their families. I completely agree with that, but I believe it's much worse than that. If we believe in human rights, then the primary role of an addiction service is to keep people alive. And on these figures, they're completely failing. The systemic failure is in addiction services in what we all work towards. Poverty is a major contributor of addiction problems, but that has not increased enough to explain that. The Drug Death Task Force was introduced 3 years ago because we had hit that level where the drug deaths were at a world record level. It was intolerable. The Drug Death Task Force's aim was to bring that down. 3 years later, that figure is 12% higher than it was then. So we need to understand not only why our services are failing and why these drug deaths are there, but we need to understand why the Drug Death Task Force failed. There's been suggestions that it's to do with a lack of powers, that we need more powers from Westminster. And they point to the fact that in comparison to other countries who have full powers, that they don't have the same levels. We have shot through the roof for some reason, and it must be that. But that doesn't explain how we were better in the past, because we had the same powers all the way from 1999. We had the same powers. It's gone through the roof recently. The best explanation I can see is that it's to do with how our services have changed. Something has changed in how we respond to addiction. I think the clues are in some of the language that we use here, medication-assisted treatments. That is used to describe methadone and Buvidal. But the word assisted says that the treatment is not the medication. The medication is to assist the treatment. So the treatment is not these drugs. The MAT standard says that the system that provides MAT standards is psychologically informed. One of the problems that we identified over and over again is that people are getting appointments for the methadone, they're not getting any psychosocial support. People will have an appointment once a month for Buvidal for 10 minutes. There is no opportunity to be doing psychosocial support. And yet, the signed guidelines for buprenorphine, Buvidal is indicated for the treatment of opioid dependence with a framework of medical, social and psychological treatment. The Orange Book that Marie mentioned this morning, for drug problems for which medication is usually a necessary component of treatment, psychosocial interventions need to be offered alongside medication. Drug misuse treatment involves offering a range of psychosocial treatment and support and interventions, not just prescribing. Treatment for drug misuse should always involve a psychological component to help support an individual's recovery. So our services aren't doing what they're meant to be doing. And I find it hard to see beyond this as one of the main changes, because in recent years there has been a shift of responsibility and funding from social work to health boards. And you know, there's an old saying, if your only tool is a hammer, every problem looks like a nail. And if your only tool is methadone or Buvidal, or if you're a medic and you're given a problem, you're going to treat it like a medical problem, even if, you know, maybe you shouldn't have been given it. So, the reason that medication must be provided alongside psychosocial interventions is that medication only treats this physical dependence that the body has on the substances. Medication cannot treat addiction, the relationship between the mind and the substance, nor the social context in which addiction and recovery exist. The treatment of addiction requires psychosocial interventions to allow the individual to change. Our case studies have shown, in support of many other studies, that psychosocial support in many cases is simply not provided. There appears to be a complete reliance on dependence on medical approaches that maintain physical dependence on opiates, but cannot bring about change. So this is kind of by looking at how the evidence from our case studies and other clients inform our view of how the system's working. I've kind of put this together, and it starts with, at the top, if you've got a system that depends, that is dependent on medication rather than psychosocial supports, then you're going to accumulate more service users every year. You're going to require larger case loads for each member of staff each year. It's going to allow less time to devote to each individual. It's going to allow less and fewer contacts. It's going to result in more problems missed, and it's going to result in more deaths. And that looks to me like the system that we've got right now. But how to change that we can't just keep doing more of what we're doing, because it's going to just spiral even further. We need, in this kind of system, we need off-ramps for clients to come out of the system to reduce the capacity on statutory services. And the only way we can do that is if there are more referrals to residential rehab, more referrals to other types of psychosocial support, that there are more community addiction services. Our communities used to have charities in every local deprived community. Most of them have disappeared. We have new services sprouting out now, like lived experience communities and organisations, but they need support because they're not going to grow quick enough to resolve this problem. And we need increased training in psychosocial interventions across the board to help more people to recover. And the good thing about this is we've done all this before. when that graph was at a lower level in previous years, that's when we did all these things. A possible way forward is that we need to admit the scale of the problem. The drug-related deaths crisis is out of control. We need to admit that the statutory services are completely overwhelmed. Psychosocial interventions have been abandoned in favour of more medical approaches. Local community-based organisations have been decimated. Without a complete change of direction, it's likely to get worse. And we don't have the adequate mechanisms of accountability. But if we learn from the past, we can learn what worked. We can start treating addiction again, as well as managing dependence. We can reintroduce psychosocial interventions for all service users as the guidelines dictate. We can reinvest in more residential rehabilitation services, replace the network of community-based voluntary sector addiction support services, and refocus training across the board on therapeutic relationships. Because that list of problems I identified earlier, if there was a therapeutic relationship in place, there would be no need to implement complaints procedures to deal with disagreements over treatment choices. And then we can make it better than it was before. Committing the 7% to total addiction funding to lived experience organisations, to reintroduce ring fencing to general addiction funding, greater accountability mechanisms and hopefully including advocacy services, pass the recovery bill to allow people the chance to challenge decisions, and the work that Professor Miller's doing on human rights to bring equality to the people who are currently being overlooked. And that's all I've got to say.